that capacity. I just want to take a few minutes. You all know a little bit about me, having come into the program, but I also want to welcome some special guests that are here today. And so we have Professor Gail Gongaware. How many of you are in Professor Gongaware's class? Okay, great. So Gail will introduce herself and tell you a little bit about her. We also have Deborah Wilson here. How many of you have Deborah Wilson? Okay, and then Professor Baird is running late, so I'm not sure she's going to make us to join us tonight. I also want to welcome some special guests that we have here. We have Linda Grady in the back there, who's going to join us as a clinical instructor for the spring, and we're delighted to have her. She's a longtime community health nurse, and she's going to be working with us, with students during their clinical experiences. And then a very special welcome to Professor Margaret Alexander, who is going to lead our Haiti international trip in January this year. First time that we're doing that. Not first time for Margaret, she's an old hand at this, but we are so appreciative of her support and her efforts in organizing and running this trip, because it's a great big launch for us. And students who are going on this trip, this will serve as their community clinical experience, and how wonderful to be able to have an international community experience. So we're delighted, and I'm going to ask Margaret to say a few words a little later about the trip itself, but more particularly about her experiences in working in the community, especially in her homeland in Haiti. So welcome, Professor Alexander. We're delighted to have you here. So let's get started, and I thought it would be fun to have you introduce yourselves and tell a little bit more about your background. I know some of the students know that from being in your course sites, but we want to get more of a real feel for your experience in your profession as a nurse, and also how you came to be a community nurse. Why did that become one of your focuses? So we'll start with Gail, and then we'll move down to Deborah.
So my name's Gail Gongaware. Nursing was a second career for me. So the work that I did before, I know led me into community nursing. In my prior career, I worked with juvenile delinquents and emotionally disturbed adolescents in group home settings and community settings. And I was the director of a program that provided wraparound services for the community. So I was already very comfortable in people's homes, and very comfortable with the concept that
Sorry, my fault.
Oh, that could be it.
Back to shouting.
that good care and good things can happen in the home, and people should be able to stay at home where they belong. As a nurse, it became very evident to me as I progressed through all the courses, where they said, okay, now you're going to rotate through med-surg and surgery and the ICU and maternity and peds, and I went, yeah, no. Psych maybe, but the rest of it was no. And as soon as I was able to do my community placement with the Visiting Nurse Service of New York, I said, I'm home. This is what I want to do, and this is the organization I want to do it with. So I was very fortunate, after a year of training and becoming a critical care nurse now. But I did that for a year at Lenox Hill. I was able to come and work for the Visiting Nurse Service of New York, and that's what I do today. And I've held very different positions within the organization, and currently I am one of their education managers for clinical training of our case managers.
Thank you, Gail.
Hi, and I'm Deborah Wilson. Can you hear me? Let's see, my career started over 40 years ago, and I actually came out, my first job was at Sloan Kettering, and I stayed there for about 6 or 7 years, and I really enjoyed working there, but I wanted to expand my knowledge base beyond cancer. So I wound up going over to NYU, where we practice as senior nurse clinicians, and we worked along with the attending physicians. And a lot of the focus was on, it was a unique environment where the patients stayed in like a hotel room, and we brought their caregivers in to stay on site as well. And a lot of the focus was on teaching them and preparing them to be self-sufficient in the home. And that's when I started thinking about home care. That was about the height of the AIDS epidemic, and when you started to see a change in acuity in the home. So I actually started out as an infusion nurse, going into the home, providing infusion. And believe it or not, I never, when I was in nursing school, I never really thought community health nursing was where I was going to be headed. It was actually the one area that I didn't like, that really didn't like. So when I actually went into home care, I immediately fell in love, and that's when I decided to pursue my master's and make it, my lifetime career. Right now, I actually work along with Gail as an education manager as well. So after practicing in the field for many years as a case manager, coordinator of care for patients and their families, now I mostly work with new clinicians who are coming in into community health nursing.
Thank you, Deborah. Very informative. And as long as we're telling war stories about how we got here, I thought I'd share a couple of things, and I won't make the microphone scream, so I'm going to just sit here so I don't hurt people's ears. So I actually, Deborah and I came to know each other because we were actually in school together, getting our master's degree in community health nursing. So you never know who's sitting next to you, what you might do with them 10, 20 years later. That's a scary thought, right?
It is a small community.
So I actually got my interest in community nursing from working in the emergency room of all places. I spent 10 years working in a mid-level emergency department, and I began to realize all the people that came in didn't really need to have come there if only we had worked with them to prevent the emergencies in the first place. And I realized the value and the importance of education, teaching, connecting people to services and so forth. And that really sparked my interest for going back to school and getting my master's degree in community health nursing / public health at Hunter College. It was a new program at the time, and I just fell in love with the idea. And I actually took that knowledge then, and I worked at Queensborough Community College and launched a community nursing component to that associate degree program, and made a lot of partnerships and friends throughout the area. I learned how to use a map because I would always get lost. I grew up in Brooklyn where the streets were numbered, 8th Street, 9th Street, 10th Street, 11th Street. And then I came to Queens and it was 63rd Road, 63rd Drive, 63rd Avenue, and I was lost more times than I can count. Nowadays, piece of cake, you have your smartphone, you have Waze, you have Garmin, and so forth. But and then I had these big giant maps and I had to figure out how to get from one place to the other. So that was my fun adventures in learning. But I learned a lot from the patients that I cared for in those home settings. Some of the conditions were unbelievable with which they had to live, but I was always most struck, I think, by the generosity of the people. Sometimes people had literally nothing, nothing that I thought they could share, and yet they were oftentimes the most generous of people because they opened their hearts, they opened their homes, and they said, if you don't have, I will share with you. There were instances of people being abandoned by their relatives at a time of need, pregnant, sick, and their neighbors opened their doors and said, well, you can stay with me, you can live with me, and didn't ask questions about how they were going to feed them or how they were going to find money to support them, but just, you're welcome to my home because this is a time of need for you. And that was always the most striking thing for me in regards to working in community settings. I often find that the students that I worked with at the time had a lot of difficulty transitioning to community nursing because you're looking at it from a different perspective. Students were very task-oriented, and so they would be a little lost. I don't have my routine where I'm doing blood pressure and morning assessments and AM care and giving out medications, and they didn't quite know how to grasp what it was like to be in a community setting. And so that was fun to challenge them and to help them come to respect and to see that there's a lot that goes on. Talk about critical thinking, figuring out how do you do things when you don't have supplies, when you don't have the closet down the hall in which to run and get things. It was an interesting challenge, and I know that Gail and Deborah would have some interesting stories in regard to that. And I think I just saw sneak in Dr. Baird, and so I'm going to invite her up to the front here and put her right on the spot without giving her a chance to breathe, and say, welcome, Dr. Baird, we're so glad to have you. Again, another one of our wonderful community health nurses and also a community health instructor in one of our courses. So welcome, Dr. Baird.
Hello, everybody. I apologize for being tardy. I don't know why. I was on autopilot and I went to the other building. So welcome.
So we were just introducing ourselves and talking a little bit about sort of how we got to the role that we're in. And I know that you've had a very interesting career, and we don't have time to spend all night listening to all the wonderful things that you've done, but I thought maybe you could channel some of that and talk from your perspective of working in the community setting. I know you are a geriatric nurse practitioner, and you work with a lot of elderly and still do, and so maybe you could share some of how did I get there? Like, what was the driving? Deborah shared with us how she was at Sloan Kettering and what sparked her interest in becoming a community nurse. Gail shared with us how this is a second career for her and the population she was working with. She felt she wanted to be able to do more. So I wonder if you could shed some light and insight to us.
So I was working at North Shore Hospital on Community Drive, and I wanted to be an IV therapy nurse, and the position became available in the community, and I applied and I started community health from there. And then I just gravitated towards the elderly population. I love listening to stories. I love learning from their experiences, their life stories. These are things you can't learn in a book. You just have to live long enough, and they do. So I just love the elderly, and it just blossomed from there. So I just love community health. I love being able to give back to the community in a way that I hope when and if I turn 80 or 90 or 100, people will be looking out for me as well.
Thank you very much, Dr. Baird. So I thought maybe we could share some insights and thoughts about, you've worked in community nursing now, community health, for a number of years. Collectively, we probably have about 100 years, right? And so what is your vision of community health nursing in particular, and where do you see it going from the state we're in today? We want to start with you, Gail.
I think community health is just, the practice is just moving so fast, and of all the different things we're being asked to do now in the community. I think, when we all started our practice, what we saw in the general med-surg units are now at home. And more critical care is happening at home. People are more of this, now what? You can get a knee replaced, a hip replaced, you're home the same day. None of that's staying over like it used to be, for weeks. People are coming home. If you just need infusion, you're home. We're there to do that. It's a lot more about the bottom line now for finances. There's a lot more pressure, I think, in community health for that care coordination and looking at positive outcomes to prevent that rehospitalization. With where the monies are now, where they're not getting, the hospitals are no longer being reimbursed for that readmission. So it really falls on the public health nurse to do what we can do to help prevent that, and working more as an interdisciplinary team and a partners in a partnership. What do you think, Deb?
So maybe you can add to that, Deborah?
Like Gail was saying, a lot of it has to do with cost, as well as what we're seeing a lot of is also the occurrence of chronic illnesses, where you have people who at a younger age are getting chronic illnesses, and they have to learn how to live with these and manage these illnesses throughout the years. And so that's an area where we've seen a big expansion in community health nursing. And also, not just the patients themselves, but their family members, because whenever you're in a community, it's the patient, the caregivers, and it's also the surrounding community who are going to be their support systems as far as helping that patient manage and where they might need to go for services.
So 2 things they said: partnership and I just forgot. Partnership, and you said something that reminded me of the fact that now we have to collaborate, work together. So for so long we worked in silos. The hospital did one thing, community health did something else, other agencies did something else, and now we all have to work together, and it's called building a culture of health. And to really operationalize that phrase, a culture of health means that you really meet patients at their level of need. We have been saying that we were going to do that. We were doing that for years. And now we realize the extent to which we have not met patients at their level of need. We thought we were, but what we were really doing was spot checking. you know, we took care of this, and then this happened. We took care of that. And now, collaboratively, in partnerships, we are working together with agencies, not just in healthcare. When you have a patient who has pneumonia, you think, oh, they need medication, they need treatment, but do they have a house that they can go back home to? Is their house, does it have insulation? Can they afford their electricity bill? Can they provide heat? So we're not just thinking about the disease anymore. We're collaborating with agencies that provide heat for patients, believe it or not. We are all coming together to really meet patients at their level of need and not just saying, well, you have pneumonia, here's your prescription, and good luck.
Well, thank you very much, Dr. Beard. Again, always interesting perspectives from all of you. So in thinking about that, I wonder if you could reflect on the change in your perspective from that first nursing job that you had in the med-surg unit of whatever hospital you may have started in, and how has your perspective evolved or changed from that time to where you are now in your community health role? Let's start with you, Deborah.
Yeah, like I said, my first job was at Sloan Kettering, and I think Gail had a good point when she said a lot of times it was you went in, you took care of your patients, you made sure they tried to get better, or in a lot of cases at Sloan Kettering, you helped them through the dying process, and that was it. You went home at night. As I went into community health nursing, and I was a coordinator of care, I was actually responsible for coordinating the care sometimes of 30 patients. So when I was looking at it in those terms, I was like, okay, how am I going to help this family member? How am I going to help this patient manage their illness, understand their illness, and really use their resources within their community? So I really look at it now. I don't think of it as, like you were saying, just one area. I think about what are all the factors that are involved that may contribute to that patient's getting well or that patient's illness. And many times it's not just limited to the illness itself, but thinking about the support systems, thinking about what other types of stressors might exist in that environment that contribute to that patient getting better or not getting better. And so I really look at it, like you said, in a more holistic way.
Gail, maybe you can add to that?
One of the things that really bothered me at bedside nursing, I'm going to say this right from the very beginning, is I remember standing there and really having that insight of these guys, they're in my house, quote unquote. I have them stripped down to some gown. I don't even let them get out of bed to go to the bathroom if they're going to fall, because heaven forbid should they fall on my shift. Don't move. And they have to do what I tell them. It's time to take your medication. I don't want to. I don't care. That's my, I'm doing rounds. You're getting your meds right now. I bring the food in. They get fed what I give them. They have to do everything that I said, and they really have no say in the matter. And even when it comes to discharge planning at the very end, I had this wonderful, sheets of paper we went through. Looking back on it, all they said was yes, 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 because what did they want to do? Go home. If they're, heaven forbid, they said no, or could you explain that again, we might kept them another day, and they didn't want to do that. So that perspective of being on the other side and actually being in home care, just the privilege of letting me come into their home. I mean, that's their home. And I wanted to be that nurse to say, there was this little old lady in the hospital that we didn't let her do a single thing for herself, and now she's at home by herself, and it's the next day. How is that? How is she going to be doing that? And I wanted to be the nurse that walked through the door that said, I'm so glad that you're home. Just as glad as you are, maybe even happier. Let's see what we can do, and we're starting from here. What do we need to do to get you healthy, to keep you here where you belong, at home, and what does that take? So that was, to me, that was, community. I was in at 100% with that kind of a practice. That's what I wanted my nursing career to wrap around.
Can you add any other perspectives to that, Dr. Beard?
So when I graduated from nursing school in the 80s, it was very provider-centric. So you hear that a patient had a diagnosis and you thought immediately, okay, this patient has asthma, I'm going to go in the home and teach them the triggers, teach them how to take their medication, I'm going to educate them. And we were so fixated on educating patients, we never said, Ms. Smith, Tell me what you know about asthma. Tell me what you'd like to learn about it. Tell me how it affects you. That part of the conversation never occurred. And now I see the pendulum has swung, and it's so provider-centric that we ask these critical questions. We don't go into the homes anymore with these assumptions that I'm here to tell you so you'll get better and live longer. It's I'm here to hear from you, to understand what it's like for you to have this disease, and for you to tell me how I can help you. And that's how I see that nursing has changed, and I'm loving it, loving it.
So a theme that I keep hearing is it's grown beyond that one encounter where, as you mentioned, this person has asthma or this person has pneumonia. I'm going to just treat that disease. And now we're looking at how do we integrate health for this person who had the experience of having the pneumonia or the asthma and now still has to live with that and the consequences of it, and yet integrating them into their whole life and being more holistic, as you so aptly put, Deborah. Thank you. I wonder if you could each share something that surprised you about practice, and maybe share a memorable story about a memorable patient that had an impact on you in your practice as you've gone through the years. Maybe we can start with you, Kenya.
I've had so many patients. Oh my goodness. I guess I had one elderly patient who taught me that it's not about the technology, our ability to keep people alive forever. It's about the needs of the patients and what they want. And I had an elderly patient who decided that she didn't want her disease treated anymore. And that was really hard for me to deal with, because I looked at her as this vibrant elderly lady, but she still had her mental faculties, she was still ambulatory, she still got up and put makeup on. And I was like, no, what do you mean you don't want the treatment? And I felt that the education that I had received didn't prepare me to deal with patients who said, no, that's enough now. I'm ready to go. And I'm like, no, but we have the power. We can keep you living forever. And she taught me to listen to what's important to patients, and to be able to accept what they want, even when I feel like they can live another 10 years.
Great story. Thank you. Gail, do you have a memorable patient?
Is that me?
No.
Yes. Again, it's learning from the elderly patient. I had a patient who was, I worked with her over a period of years from when she was 95 to 101. And when I first met her, I had this, probably a lot of biases. You read the chart, you read what you get, so you're going out and I'm saying, how is this woman even living at home, let alone living at home by herself? I think that my job is going to be to convince her and to really lay out the plan that she needs to be in a nursing home. Silly me. And she proceeded to just explain to me how it didn't matter that she needed total assistance to get out of bed into her wheelchair because she could no longer walk, and it didn't matter that she couldn't see anymore. That she needed to be at home, and that she had built over the years such a supportive network, minus family, because she had no family, no children, and her husband had been dead for a long time, but she had built in such a network that every time I went, okay, who is this in the home today? Oh, that's the local dog walker, and I really like dogs, and they come by every day with the dogs. I'm like, okay, that sounds like fun. Then another neighbor had partnered her with one of the schools that do like those school projects, how kids have to do community work. So she had these high school students coming in once a day to read to her from her favorite novels that she missed reading over the years. There was I don't know what the yoga person was doing in there, but she came in and did yoga with. There was always people in and out of this house, and that's where she belonged. And so I really had to switch my perspective, and it's not what I want coming into the home or what I think is best. Again, it's what they wanted. And yes, we had to deal with the with the illnesses that were going on and what was making it best. But I would say, okay, so she goes, I'm never leaving the home again. I said, what do you mean you're never leaving the home again? So what if you have a toothache? I'm not leaving the house. She you'll find a dentist to come in to deal with my teeth. I said, well, okay, and we did. I said, well, what if she fell out of bed with, I thought she had a broken hip. I said, so if you break your hip, we're going to no, you'll bring an x-ray machine into the house. We don't have to go out of the hospital. We don't have to go out of my house anymore. I'm going to stay here. And stay here she did until 103.
Wow.
So it's that kind of perspective. Like, people want to be at home, and whether I think it's their home, you have to leave your biases at the door. That's where she wanted to be, and she was very comfortable there, and was able to spend the rest of her life there, which was a good thing.
Thank you for sharing that. Deborah, I wonder if you have a similar kind of memorable patient among the many that you had.
I think my patient is elderly too, even though I have a broad spectrum of patients that I see. And when I first went out into the field, like I said, I was so excited about teaching the plan and making a difference. And I remember going into the patient's home, and she was diabetic, and she was an elderly woman. She lived with her son, middle-aged son, and he wasn't employed at the time. And I went in with this whole big teaching plan about diabetes and diet and everything. And when I was done, I was like, so what do you think? What do you think? And, she said to me, it's the end of the month, and a lot of those meals sound, very interesting. But she said, my food stamps have run out, and Social Security, so maybe the beginning of the month I'll be able to, buy some of the foods. And then, that's one of the things about home care is you're able to look into the cabinets, look into the fridge. And I didn't know what to do. I was like, oh. And so I called my manager and I said, I don't know what to do. And she said to me, well, do you have any money on you? And I said, yes. And she said, okay, I want you to give her the money, we'll reimburse you. And then we'll get a social work in there, and we'll do this and we'll do that to sort of, help her out. And that's when I realized, many times there are other factors that's involved in how patients can manage themselves. And even, as I went through my career, like even if they can't go to the emergency room, you're thinking, well, they don't want to go, but maybe there's other factors that, just like you said, they can't afford the ambulance, right? Or they don't have anybody to take care of their grandkids. So I think it really opened up my eyes to a lot of the other factors that played into a role as far as, what makes patients ill or not able to take care of themselves, or what type of other things might they need to support them.
That's a really good point, because I think sometimes we look at patients and we expect that they are going to follow the plan of care, and then when they don't, we label them as being non-compliant. And a lot of times I think it's because we don't understand what their thinking is. And I think back to a story that I used to illustrate that when I was teaching my students about these kinds of concepts. And it was a gentleman from another country that didn't speak the language well and had some heart issues, and so he was brought in for an evaluation, and they determined that he was going to have surgery done, a cardiac catheterization to address it. And he was adamant, he was not having this done, and there was no amount of interpretation, the dialogue, the interpreter came in, explained to him that there was no amount of understanding that would make or convince him that this is something that he was going to do. And when we peeled back all the layers, which is kind of what you talk about, his perception of what that surgery was going to involve was that someone was going to cut open his chest and take his heart out of his body and bring it to the operating room and operate on it. And there was no way he was going to let his heart leave his body. So his perspective on that was something that we didn't understand, because we didn't peel back the layers, and we didn't know what are the other factors that we sometimes think of a patient being non-compliant, but oftentimes it has to do with the way that they're thinking, or as you mentioned, gee, if I leave here, who's going to let my grandchildren in? I have that responsibility. So always to be open-minded in that regard. So thank you for sharing that. Some other things I thought would be interesting to talk about. One is, what was your biggest surprise, your aha, of working in a community setting? I think you've shared a few of the things, but I wonder if there's something like made you stop in your tracks and say like, oh my gosh, what am I doing here, and how am I going to get this done? Maybe you could share some of those kinds of experiences. How about we start with you, Gail?
I think one of the biggest surprises for me was something I anticipated but wasn't really sure it was going to happen. But the fact that it is I'm in somebody's home, I've come in and I've done my clinical assessment, I see some red flags, maybe it's medication reconciliation that's not matching up, and I'm being told from my orientation instructor that, well, now what you do is you just call the doctor and he'll listen to you. And I'm like, from the hospital, no doctor ever listened to what I had to say. There was no, that was always my experience in the hospital. Your hands started to sweat, you're like, I can't call the doctor. They don't want to be bothered. And in home care, my experience, what really surprised me was that they truly did want to be involved. They had signed that initial order for me to go in the first place. And in my assessment and my opinion counted, and they listened to me and said sure, and actually gave me verbal orders that I had to write and send in for authorization. And it just surprised me so much. And then he sat up a little bit straighter and he said, well gosh, and that's one of the things I so much enjoy about the community nursing is that independent practice. That and you really are recognized for that. And again, it's working as that team and the physician, and now things have changed so much where we to your point, we no longer operate in that silo, and we really are a part of the team. And as a visiting nurse, I'm a valued part of that team. Frequently, the leader of the team. In my mind, the doctor might think he's a leader, but I'm the one in the home, face to face. And if I can do. Here's the other thing, like the other day, if I can call him and I'm giving him signs and symptoms of CHF exasperation, they don't have to go to the hospital. We can diarrhea some. He can give me an order over the phone, PO, double the Lasix and go back and see them the next day. We can do that. We don't have to. I don't have to take them out of the home and get them to the doctor's office or maybe get them to the clinic or the ER. We don't have to do that anymore. I'm that voice for that person in the house, and that never ceases to amaze me, like how much respect that you can have in being a part of that team.
Interesting, not just respect from the healthcare team, the physician, but also from the families. What you have to say is really important, and they listen to what the nurse says. What will the nurse say? So that's a great illustration of a good perspective, a good aha moment. Deborah, maybe you have something else that you can share with us.
I think I have to reiterate what Gail was saying as well as, nursing being such experts in the field, especially like at VNS when it comes to wound management, we really become like experts. And many, like you said, many of the physicians and so forth look to us. But also when it comes to the influence or the role that you have in helping family members do things that they never thought they could possibly be capable of doing. I know many times we'll send patients home and they may have wounds or they may be new diabetics or just do treatments that they've never really thought that they would ever be doing. It might be an elderly patient with an elderly wife and you're saying, okay, so you're going to learn how to do this wound care and pack this wound, and they're looking at you like, no, I don't think I'll be able to do that. And then 2 weeks later, they're doing it with such expertise and managing it. And, so many things that they didn't think that they would be able to do as far as caring for their caregivers or having the knowledge to do. And as clinicians, we're able to sort of motivate them, guide them, and really give them that confidence to be able to manage themselves and take care of themselves. So that was a great area.
I think that's a great example of looking at your role in a different way. I think sometimes when we're new nurses in particular, we tend to think, well, we're the nurse and we know how to do this and we're going to do it the best. And we forget that a lot of the things that we do are really just skills and tasks that can be taught to somebody as long as you frame it in the correct way. And that's a great illustration. Yes, we can teach this person to manage that wound or to suction that trache or to change that dressing. It's a skill set. And what makes us different? Well, we're the nurse. We recognize that that could be done. We identify how we're going to go about teaching this person in order to do that, and then making sure that they're doing it correctly and carrying out the proper technique. So, great example. Thank you for that. Kenya, maybe you can share with us another aha, surprise.
My biggest aha was probably understanding and realizing that I had implicit biases, and that we all have implicit biases that when we see a patient's zip code, when we see them, when we see their house, when we just see things, we make these associations based on our prior experiences, and they can be so far from the truth. And it's so easy for us to say, just be mindful of your biases, but they inform sometimes how you practice. So it's very, very important for you to do that self-reflection. For me, it was a patient who came onto home care very late with end-stage cancer, breast cancer, and I'll never forget the wound and getting a report that, oh my goodness, the smell was horrifying because it was just necrotic, dead tissue. And I remember saying, who would wait that long and again, you have these assumptions. And it wasn't until about maybe the 5th or 6th wound care visit that we started to develop this bond, and she trusted me, and she shared her story. And when she shared her story, I was just blown away. And I felt she didn't know, but I felt internally so bad because I thought differently until I heard her story. And that's when I realized, we shouldn't expect people to have to share their story with us for us to say, wow, and to feel differently about a patient. We should just feel that way towards everybody, not having to hear that so-and-so has this or that, and oh, now you feel bad, so it changes how you deliver care. We should feel that way towards everybody, and it goes beyond being compassionate. It really captures how you truly believe people are, what your assumptions are about them. You don't have to share them with anybody. It's not an AA program where you have to stand up and state your name and say, I do blah, blah, blah. But just really think about what your biases are before you go into care for a patient. Recognizing it is the first step, and then trying to control it so that you deliver quality care to everyone. Because when I look at the maps, in the United States, and I see that the quality of care for patients across the country is different. The Institute of Medicine report, the Agency for Healthcare Research and Quality, they speak to the fact that providers treat patients differently. And it might be because of their zip code, it might be because of their height, it might be because of their LGBTQ population, or their gender, or their size, their BMI. And when you think about it, we're all in this profession, healthcare, to make a difference in the lives of others. So we do have implicit biases. We have to recognize it and really control for it. That was my biggest aha.
Great point, and so true. Trying to check that at the door, and as you say, the first step is, being aware of it. It's a very powerful moment when you realize, oh, I made a wrong judgment here. I thought something that wasn't real, and I just did that based on my assumptions as opposed to really assessing the situation, the person, the family, etc. So, great point. I wonder if you might share with these students who are in your community nursing courses some recommendations about what you would suggest for them who are considering careers in community health. What would be some ideas, thoughts, recommendations you might give them as they explore that idea? A lot of our students, not all, but many of them are brand new graduates, want to get that 1-year med-surg experience. I happen to have a different philosophy. I don't think med-surg is a be-all and end-all of things. I don't think getting 1 year of med-surg experience is what you have to do in order to be a nurse. I do believe that if you have a passion about something, whether it's community nursing or obstetrical nursing or pediatrics, then go where your love is, because all 1 year of med-surg in a hospital does for you is enhance your time management skills, your organization skills, etc. It's not, to me, really about making you a better nurse or a more knowledgeable nurse. It's really just getting you into the role of what you do in a hospital setting. So that's a little bit of my bias and the perspective, but I wonder if you might share some recommendations for any students who might be considering careers in community nursing. There is a perspective out there, and it's pretty rampant in schools, even among faculty as well as in hospital settings that you're not a nurse unless you at least have 1 year of med surg under your belt, and then you can go from there. Again, not a philosophy that I endorse. So what do you have to say about that, Gail?
Well, I have to agree, but they forced me to do that year, going in. Because at the time, the Visiting Nurse Service of New York did have, and that could be, that's one that you could look for. At that time, they did have an internship program for new graduates, where they actually, for a whole year, supported you through that transition. They offered me a position in Queens, and I went where? I wasn't from New York City at the time, and I never went above 53rd Street in Manhattan. I don't know how they thought I was even getting to Queens. I lived here in the city in a car, please. So I had to say, no, let me go to the hospital. I keep calling, at 6 months and 9 months. Can I come and interview now? I've done my time in the ICU. I think one of the things that you have to have confidence in your practice. And again, to what Marge is saying, if it's passionate, if that's where you want to go, you keep that passion, but you have to have strong assessment skills and strong critical thinking skills. You have to have those, and how you develop them is up to you. Whether that's that year in the hospital, that's going to help you develop that, along with all the other skills that you said. When you're starting out, you need all of those skills, but in home care, it's such an independent practice that you really do need to be have those assessment skills. It still amazes me when I speak to the students that are going into their clinical settings for community, and I say to them, you're going to have to take a blood pressure because there's no machines that just, you push the button, and like in the hospital, that's all you've been doing. Like you really have to get the stethoscope out again and do that. And you see these looks in it in their eyes, and I'm like, no, I really mean it. Like you have to know how to take a blood pressure again that you learned way back in the day, because in the hospital you don't do that anymore. Everyone's hooked up, and you're just watching what's going on. It's those kinds of hands-on skills again that you have to be able to do in the house. And I think, and I guess another recommendation I would say is, again, if you're passionate about something specific, those passions also exist in home care. If you want to be a diabetic specialist, great, and we have them in home care. If you want to be a wound care specialist, please. People are coming home more faster with those wounds, and we need people to be in the home to do that. So if there's a specialization, Visiting Nurse Service of New York, we also have the Nurse Family Partnership, where we deal with young mothers before the birth and 2 years after. We follow them in the home. So if that's your passion with pediatrics, there's a place for you in home care. Again, a lot of that care now. If it's hospice care, we've talked about Sloan Kettering. If it's hospice, we have hospice and palliative care in the home. We need those nurses just as much in the home too. So I think it's just find your passion, and that same passion is happening in home care, and bring it in.
Deborah, what recommendations might you have for students looking to have a career in community health?
Well, one of the things I know, some things that keep people away from community health sometimes is the documentation part, because you probably hear a lot about documentation. So just like not letting the computer or technology scare you. Many times I work with a lot of new orientees, and when they come into the class, they sort of get very focused on the documentation, and they lose the fact that they're a nurse and they have those excellent skills. So I always say, don't worry about the documentation. Once you learn it, you'll get past it like anything else, and then you'll be able to concentrate on nursing. And also, like Gail said, there is a lot of autonomy. So really, like you said, being someone who's willing to reach out to others for expertise, sort of having that unspoken sort of informal mentorship or collaboration with other clinicians. One of the things I did, when I first went out into the field, is I really looked at other nurses who were experts, and I would really sort of latch onto them and get their expertise and have them share their knowledge with me. If there's a case, I would call them up. This is our scenario. Even with HIPAA, how would you manage that? And just getting their input. So because in home care there is a lot of autonomy when you're working with.
Just a follow-up on that, Deborah, with the documentation. I know that back in the day, we were in the phone booths taking the information and writing it down on paper. Now you have technology. In fact, the Visiting Nurse Service was very innovative in developing its own documentation system, and one of the first. So have you seen big changes in healthcare in regard to the documentation by using more technology? Has that changed sort of the dynamic a little bit?
Oh, definitely. So, for example, if you go into a home and say, you know, when you're out there and you're still learning about wounds, we all the nurses have camera phones. So what they do is they can take a picture right then and there. We can download the picture. We have WOCNs, our wound care specialists. They will actually look at your note, do a consult, and then consult with you and say, okay, let's look at the wound. But they'll look at everything. They'll look at the wound, the diet, the pressure of mattresses in the home. And then they'll work with you to think about, is this the right treatment? What else do we need to put into effect to help this wound heal and help this family? So what we've really seen is how technology in the home has really sort of brought to have that virtual clinician right there with you. So some of the things.
Thank you for that. And in Kenya, you have some recommendations for students thinking about careers in community health?
2 recommendations. One, know the resources that are available in the community. That is such a huge help to patients. Sometimes we just go into the homes and we're just gung-ho about whatever disease we're teaching about. You know, they have diabetes, we're going to help them get their A1C to 7 or below. And sometimes patients, that's not on the top of their priority. They are thinking about, how am I going to make my house warmer? Or how am I going to do this or that? So really know the resources. Know there are food pantries in the neighborhood. Just know the community. And the second thing is, it always saddened me if I went into a patient's home and they complained about a nurse. And it just made me sad, because when people aren't feeling well, they usually aren't their typical self. And you can probably relate to that. If you're in pain, you're probably not going to smile and laugh the way you usually do. And sometimes patients can appear difficult. But if we just put that difficulty in a bigger frame of, this person is dealing with something that might be a life-altering disease, and give them a vibe and say, you know what? If they say the wrong thing, you don't have to respond by saying the wrong thing. I think as home care nurses, it's a privilege, like you said, to go into a patient's house. We really have to understand and understand where they're coming from, and not be easily upset, because you're going to meet so many patients that might not like you just because you remind them of someone who they don't like. You have to be able to have that emotional level, that emotional intelligence. That's the second thing. That everyone should read emotional intelligence, because it's not like IQ. EQ, you can grow. So if your emotional intelligence level is low and you respond to people who irritate you, you irritate them back, you can read this book and it'll give you the tools that you need to become more emotional intelligent, where now someone says something and you don't respond to what they say in a way that's negative or takes you out of character. You remain true to who you are, regardless of the most difficult patients. You can still take care of them with a smile and say, I want you to have a good day, so what can I do to help you? Those are my 2.
Wow, powerful lesson.
Mark, I wanted to add something. I think the opportunity that you have in this program is your community clinical, and you didn't have that in your other degree. So if community is where you see yourself potentially going, or that you have an interest, I would advise you to really take advantage of that community placement that you have. There's always community. I get that. We get that a lot in the community placement. People are just dialing it in because you have to do it to get through the program. And there really isn't the interest, and okay. But if it's really something that you want to do, take advantage of the opportunity that you're having. And if it's a community opportunity that you don't really see yourself doing, but you'd rather do this, it's networking while you're there. because while you're at that community placement, you're going to meet visiting nurses. Maybe you're at a clinic, but maybe you want to do visiting nurse. You will network out to those people and learn from those people and step up and take it, like I said, just take advantage. Almost to, I think I was a nuisance in my clinical placement because I was always talking and wanting to know this and sure, I'll go and do that. Can I come along with you and shadow to do that? Oh, I just wanted to see it all and meet everybody. And I'm saying if it is something that you're considering as a different practice, that's the opportunity that you have now that you didn't have before in your other program. So I just wanted to
Great
mention
message,
that.
being willing to go outside your comfort zone. One of our students doing their capstone just had a comment that she was summing up the experience of doing her capstone, which is another level, but she had a comment that said, life begins at the end of your comfort zone. And it's really important to step outside so that you can learn and that you can grow. So a powerful message that I share with you, and I will take that message with me because I think it's so true. Learning to grow and going outside, as you said, Gail, being willing to try this, to go here, to do that. Yeah, maybe I don't know exactly everything, how to do it, but I'm willing to give it a shot. I'm willing to learn. I'm willing to ask questions, and so forth. I want to thank you for your thoughts, and I wanted to ask Professor Alexander if she would join us up there and share a little bit about talking about going outside of your comfort zone and doing something of privilege and wonder. Professor Alexander is running a trip for us for a number of students going to Haiti in January for their clinical experience, and I wonder if you might share some of the things that you have done with students in this kind of an experience. Just a great privilege to see the different kind of life that happens. Margaret's been doing this for a while now, and I remember being very impressed when I first met her and she shared this whole project that she did. So I'm so glad that she could join us tonight, and so privileged to have her here and be part of our team and be going to Haiti with the group in January.
Okay, well, thank you very much for the opportunity to be here today and to kind of tell you about what we've been doing. This started at your college, this course. However, I've been doing this for a long time, and I'm a lot older than I look.
Well, all of you are. No, you all look very young, very young. 100 years experience, but very young.
Yes. Community really started for me, oh my gosh, I have to say over 30 years ago. My older sister, I'm the youngest of six girls, poor father. I was the younger, I'm the youngest of six. The first one and myself were 22 years apart. And she was a nurse. Unfortunately, she died 4 years ago. However, we're from a very small village in Haiti where I didn't grow up there. However, I kept seeing my older sister going back and wanting to give back to the community. So that kind of fueled a passion in me to become a nurse, be like her, and really work together with her in this community. And that's what really started all this journey. The things I've done, when I first started, anytime a doctor would say, "Who did this?" And I would say, "Why?" Because I know I was going outside of my realm of practice. However, you learn to deal with what you have. And a lot of what the panel was saying in terms of learning to listen, knowing that you don't always have the answers, knowing that you need to meet the person where they are. What's important to you is not important to them at the time. And really accepting that when you come from that Western mindset, it's a little difficult at first, but you really have to kind of step back, listen, and then work with the person. And you're not going to be always right. 99% of the time you're not, because they come with a specific need. And that need is what needs to be looked at, what needs to be evaluated, and to see how much of that need you can help them accomplish. So I hear some of the experiences, and believe you me, I've done things that, taking care of people and taking care of animals. You know, I remember they brought me a cow one day because the cow went into somebody's farm and they tried to chop off the cow's tail as punishment for going into the farm. You know, and here this farmer comes to me, what can you do? You know, I don't want to lose the cow. And I'm thinking, okay, so what am I supposed to do here? You know, I'm crushing penicillin to try to create, you know, some type of antibiotic treatment for the tail of the cow. Thank goodness the cow survived. You know, and my next trip I ended up with some chickens as payment. You know, but these are the kind of things. You know, delivering a baby in the middle of the night by candlelight. You know, because I'm in an area where there's no electricity. What am I going to say? Well, the baby can't come yet because there's no electricity. You know, but over the years, it's been a very rewarding experience, and I think one of the reasons that this course that I'm sharing now with you here at School of Professional Studies started at York in the fact that, you know, I think when I first got there, students didn't really know who I was, where I was from, and of course, students want to know. I teach in a generic baccalaureate program, and they want to know who you are, what do you do outside of, you know, school. So I would smile, and they wanted to know what language I spoke because I didn't really sound like I was Haitian, and I didn't really sound like I was Jamaican. They weren't sure. So they would ask, so what do you do when you're not here? I said, if you only knew. And one day one of them said to me, you must be part of that 1%. And I was mortified because I didn't really know what a 1%er was, you know, in terms of Haitian culture. So I went home and I'm asking, my goodness, can anybody tell me what a 1%er is? And I'm looking up. It's their way of saying, because of how I guess I carried myself and because I was here, and especially what they were hearing on television, social media about Haiti, they assumed that I was part of the rich crowd. And I said, if you only knew. So this course started in a way to show them, never judge a book by its cover, you know, because sometimes you think something is and it's not. So the course was a way to open their eyes to, just because you see somebody standing in front of the classroom doesn't mean that I don't carry, you know, a village with me. And so in developing the class, I said, the course, I said, really, now what do you guys know about Haiti? Yeah, and then of course it's, they're the poorest country in the Western Hemisphere, you know, that's where AIDS started. And I said, well, what else? You know, and everybody was taken aback because that's all they've heard. So when the class developed, I said, okay, you'll get the 3 credits because you'll be doing work. You know, and it's not a trip where I'm going on a trip. I'm going to Haiti for service learning. Service learning usually has that dip in, dip out photo op to me in my mindset. All right, so I really needed something that was, number one, sustainable, that we can go back and evaluate. It wasn't as if we were going to just say, oh, we went to Haiti and we helped the poor people. Because especially after the earthquake, that's the image that's been given to a lot of foreigners entering the country. And the Haitian people themselves, especially people in the rural communities, they tend to have mistrust, a lot of mistrust, that people say they're coming to do, they leave, they never come back. So this took really 1.5 to 2 years to develop the relationship with the partners that I had to develop for this course. And really going, the first group that went, they had to do assessment. Okay, we weren't going to, you know, as one person said, oh, we're going to help the people. And I said, really? Well, it's good. You can expect the unexpected. Okay, that has always been, oh, Professor, what time are we starting? Clinical, you know, the clinical portion. And in the back of my mind, I'm saying, well, we're not in the States, that's for one. You know, clinical doesn't start at 8 o'clock and finishes at 4. it starts at the crack of dawn and we finish when every patient is seen. So that in itself had a new way of thinking because, but don't get me wrong, they were well compensated. We stay at a beach resort that's secure enough that we know there's an issue, there's control, in the environment that we're staying. And it's more an area that they kind of support people coming in to do work within the community. So I really look forward to going back and seeing the kids as they develop. We work in an orphanage, and I've been back and forth seeing this little boy who's now 4 since he was born. So even the students, they'll say, oh, did you see Noah? Oh, did you see the twins? So there is a relationship that develops. There's a true partnership. And whatever we do, we have to have sustainability in what we do. So those of you that are traveling with me, I look forward to it. And one thing that I tell my students, once you connect with me, it's a lifelong commitment because I will definitely call upon you. Over at York, once the students take the course, they have to do, that's my expectation, that they have to do presentations. And I think Dr. Beard has been at conferences where we both participated, that my students, I drag them along everywhere I go. Unfortunately, tonight was not the case, but at least one of them is usually with me. They've presented through Sigma. They've traveled as emerging scholars that they presented at Sigma at Vegas in July. They were in Cape Town, South Africa, also presenting their poster and podium of the work that we've done in Haiti, and it has been continuous. So I look forward, and thank you very much to School of Professional Studies for this opportunity to really share what we do at York and what I do personally.
Well, thank you very much, Margaret. We appreciate you joining us impromptu and be able to share your experience working in the community. I know we only have a few minutes left, but I wanted to open the floor if anyone had a question that they wanted to pose to the panel, a thought or comment. Andrea.
What is your experience with patients who have a mental health diagnosis in the community?
Okay, did everyone hear that question? Okay. Someone want to answer?
From our point of view in terms of, in the Caribbean, mental health is a very, very touchy issue. It's a very touchy diagnosis, and I can speak for Haiti. Now mental health is at the forefront. Before the earthquake, mental health was something, mental health and disability were two areas that, were sheltered in the household. And one of the reasons that I speak of disability, for example, that's my research agenda. I'm currently a doctoral candidate, and my research agenda is really looking at traumatic amputation since the earthquake, as a result of the earthquake. And when I've looked over the years, now people are out with, lost limbs, that they're in wheelchairs. Years ago, they were hidden in the household. If there was a patient or a family member with a mental issue, they were never seen on the outside because it had social connotations to it, where other families, oh no, we're not going to marry into that family. They have issues, But now, mental health has been introduced to the forefront. You'll see that patients are now going to psychologists for therapy, going through psychiatrists, for their different problems that they experience. And again, it's to be aware and to advocate for those without a voice, which is key.
Deborah and Gail, doesn't the Visiting Nurse Service have a mental health outreach program now that they try to have integrated care with the acute care services as well?
Yeah, and because what you'll find is the division that I work in is mostly acute care, so we deal a lot with acute episodes, but we do have a department now that's separate, a behavioral health department. And also, we also, like you said, collaborate with other departments that help with chronic illness, with mental health. So you have seen a lot more funding that's going into mental health and really recognizing the diagnosis. So we're definitely seeing that.
And I think that it's also, it's challenging, but it's also knowing what's in the community supports that are out there. You are in there, why aren't they taking their medications? Is it because that it's either I'm taking my medication or I'm paying my bills, or I have no housing right now. It's knowing, there's so many more dynamics that just make it so much challenging, and you can't do it by yourself. So it's really knowing where all those supports are and remembering not operating in silos, but as a team, and finding out where those additional supports are out there. And and right now it's the same thing here in the States. I think it's so much more of a forefront. There's so much more funding and grants and monies out there right now dealing with those issues where it's a lot of times it's a matter of making all those connections.
Thank you for answering. I only ask because from my work I noticed that those people who have mental health diagnosis, like let's just say depression, they have a harder time dealing with their physical problems. So in my experience, I believe that caring both physically and mentally for our residents and patients is very important. I'm sorry.
I think you make a great point, which is there's a movement towards more integration
Yes,
of
both
mental
physical
health
and
with
mental.
primary care, that we really shouldn't be isolating it in two different ways, but that it often plays a role, as you said, in how they respond to their physical ailments and illness and management of their health care. Well, I know that we're just about out of time, so I wanted to thank our panelists, including our special guest, Dr. Alexander, almost Dr. Alexander, soon to be Dr. Alexander, for joining us. Really appreciate it. I want to thank all of you for coming tonight and spending time with us. And to those of you who brought a toy or a donation for the foster care agency, that is being sponsored by the Sigma Theta Tau chapter. Hunter College and the School of Professional Studies are joint members of that chapter, so thank you to those of you who took time out to donate something in that regard. We did give you some evaluation forms. If you wouldn't mind filling them out, they can be anonymous, and then drop them at the table. Linda Grady, thanks so much for stopping in and visiting with us today. We look forward to working with you in community settings, and thank you again. I know some of you I asked to see me afterwards about some special issues, so please make sure you do that before you leave. But thanks again for your time. Great to have you here, and thank you again, panelists.
Thank you.
Wonderful job.
Thank you.
So I'd love to take a picture of you guys. I'm going to bring a picture.
I thought their picture's already being taken, right?
Thank you, Darren.